during last decades, the role of MRD in CLL changed, also because of advancement in technology, but mostly because we've seen really big breakthroughs in the therapy with novel therapies approved and widely used. So it shifted from prognostic use. It was well-established prognostic marker with chemoimmunotherapy regimens. Now we rather think about using it as in MRD-guided strategies, so as a predictive marker, for instance, to tailor the duration of therapy. And recent studies like Captivate MRD study or FLAIR showed that these MRD-guided strategies are feasible, but now we need confirmation from phase 3 studies comparing this MRD guided strategies to standard treatment, fixed duration treatment. And luckily, such studies are ongoing. For instance, MAGIC study, CLL 18, MOIRAI study by German CLL study group, or RESOLVE study by ERIC group. And hopefully in few years, we will see the results. And I cannot predict it, but I hope MRD will be used as a marker to guide therapy. So we will use it as a predictive biomarker to optimize the treatment in a way to deepen therapy or prolong therapy in those patients who respond suboptimally, but maybe most importantly to limit the treatment duration in elderly patients with comorbidities who respond early with undetectable MRD.